Stop talking about zombies. Listen to the sound of the shot. That sound means the rules changed. It means you are now the highest priority casualty, or you're standing next to one. In the collapse, no ambulance is coming. There is no heroic triage nurse waiting. It is just you and the clock. That clock is running down to 0 in minutes. If you waste a single minute worrying about a broken arm, you just signed a death certificate. We don't call it triage, we call it the Fatal Four. These 4 conditions kill 90% of preventable trauma deaths instantly. If you fail to address them in order, the patient becomes a meat puppet. The brain dies first, then the body follows. Understand this: trauma is physics applied to anatomy. The bullet doesn't care about your good intentions. It just cares about kinetic energy and the path of least resistance. We treat the problems that cause immediate death. Everything else is secondary. Everything else waits. Here's the thing. You must establish order in pure chaos. The first rule, the golden rule, the absolute dictator of the scene, is massive hemorrhage, bleeding out. This is priority 1, fatal condition 1. They are leaking their life force onto the pavement. Stop the leak, or nothing else matters. How fast can a person bleed out? 4 minutes, maybe less, if the artery is major. Forget gauze and polite pressure at first. Get a tourniquet immediately. This is not a debate over saving the limb. This is a debate over saving the life. Apply the tourniquet high and tight, directly on the skin above the wound. Don't hesitate. Don't apply it over joints or pockets. Crank it down until the bleeding stops, or until the distal pulse disappears. If you cannot feel the pulse below the tourniquet, you did it right. If it's still bleeding, you need a second tourniquet right next to the first one. Don't loosen it. Don't check it. Write the time of application on the forehead, or the TQ itself, using blood if you have to. What about wounds in places you can't put a tourniquet? Junctional wounds, shoulders, groin, neck. These are tricky, catastrophic areas. This requires immediate wound packing. You need hemostatic gauze, ideally. If not, use plain gauze, bandages, or even clean cloth if desperation dictates. Shove it deep. Pack the entire cavity. Pack it hard. Treat the wound like an empty soda can you are stuffing full of material. Then apply direct, overwhelming pressure. Use your knee. Use your weight. Don't be gentle. You are fighting physics, remember? This pressure must be maintained until evacuation or exhaustion. Once the catastrophic bleed is controlled, and only then you move to the second killer. Fatal condition 2, airway compromise. If they are gurgling, snoring, or silent, they cannot breathe. An obstructed airway is a dead casualty in under 2 minutes. Most GSW airway issues involve the face, the neck, or simply the tongue falling back due to unconsciousness. First, the simple fix: repositioning. Head tilt, chin lift. Check the mouth for obstructions, blood clots, teeth, foreign debris. Sweep it out with a finger if you must. If they are conscious, try to keep them sitting up, leaning forward slightly. Gravity is your friend here. If they are unconscious and repositioning fails, you need an adjunct. NPA, nasopharyngeal airway. Measure it from the tip of the nose to the earlobe. Lube it up with water or blood. Insert it into the nostril, pointing toward the back of the head, straight in. If that fails, if the trauma is too severe, or if the airway is collapsed, you are facing a surgical airway, a cricothyroidotomy. It is brutal. It is final. It is reserved only for when all else fails, because the infection risk is enormous. But sometimes breathing through the hole is better than suffocating slowly. Now fatal condition 3, tension pneumothorax. This is the silent internal killer. The bullet penetrates the chest wall. Air leaks into the chest cavity but cannot escape. This pressure builds up. It collapses the wounded lung, yes, but more dangerously, it pushes the heart and major blood vessels off-center. This prevents the heart from filling with blood. It's a pressure cooker for the heart. The signs are definitive: increased difficulty breathing, tracheal deviation, late sign, and diminished or absent breath sounds on the injured side. The casualty will look gray, anxious, and panicked. This requires decompression, needle decompression. This is a high-risk, high-reward move. You need a long, large-bore needle, A 14 gauge is standard. Locate the site, the second intercostal space, mid-clavicular line. That means right under the collarbone, just off center. Or the fifth intercostal space, mid-axillary line, under the armpit. Insert the needle directly over the rib, never under it. Always over. Push the needle straight in, perpendicular to the chest wall, until you hear a hiss of air escaping. That hiss is the sound of life returning. Secure the needle. Now you have converted a lethal closed pneumothorax into a survivable open pneumothorax. If the GSW is already an open chest wound, a sucking chest wound, that's a separate problem. Cover it immediately with an occlusive dressing. Plastic wrapping, a chest seal, the plastic from a bandage wrapper, seal 3 sides. Leave one side unsealed. This creates a flutter valve. It allows air out during exhale, but seals during inhale. This is temporary, but critical. Finally, fatal condition 4, shock. Hypovolemic shock specifically. They are not dead yet, but the circulatory system is collapsing. They've lost too much fluid, too much pressure. Even if you stop the bleeding, the consequences are still unfolding. Their blood pressure tanks. The body starts to shut down perfusion to the extremities to protect the core. Signs of shock, altered mental status, rapid and thready pulse, cool and clammy skin, paleness. They might seem confused or agitated. Treating shock is about heat, fluid, and elevation. Keep them warm. Cover them with a blanket, a thermal wrap, or even dry debris. Heat loss is rapid and lethal in trauma. Elevate the legs slightly if possible to encourage blood flow back to the core. If you have access to saline or IV fluids, administer them, but that's a luxury in the collapse. Mostly you manage the symptoms and pray the initial stabilization holds. This is a holding pattern. You need to move them to definitive care, which in the new world means a secure, sterile environment you create. Now let's talk advanced threats. GSW means exit wounds. Never assume the bullet stayed where it entered. Search the entire body. Check for multiple holes. An exit wound is often larger and more destructive than the entry wound. Treat both entry and exit wounds as separate catastrophic hemorrhages. Also, never ignore the spine. If the shot was near the torso or neck, stabilize the neck immediately. C-spine precaution is mandatory. Do not let them move their head. Use sandbags, boots, or bundled clothing to immobilize the cervical spine. Moving an unstable spinal fracture means paralysis or death. Pain management is psychological warfare. If you have NSAIDs, fine. If you have opioids, understand the risk of respiratory depression, especially with chest trauma. Pain management in the field is secondary to survival. Keep them alive first. Infection is the long game. Bullet fragments, dirty field dressings, delayed care. Every GSW is a contaminated wound. Once stabilized, the wound must be thoroughly cleaned and irrigated. Not now, later. Right now, you are a machine. You must prioritize. Hemorrhage, airway, breathing, circulation. Stop the leak, secure the path, manage the pressure, maintain the pump. This isn't theory. This is the difference between survival and decomposition. If you handled the fatal 4 correctly, you bought them time. That time is the only thing standing between them and the dirt. Understand the severity. Act with speed, precision, and zero sentimentality. Welcome to the new world. Now you know how to win.